Hi, and welcome. I'm Dr. Jessica Mellinger from the University of Michigan, here talking today with Dr. Shalimar of the All India Institute of Medical Sciences in New Delhi about anticoagulation and hemostasis in cirrhosis. Welcome, Dr. Shalimar.
Thank you.
Thanks for being with us today.
Thank you.
So you really wrote a great article for CLD, kind of talking about a pretty complex topic in cirrhosis and something that I know we all struggle with, and which is how to manage hemostasis, anticoagulation, and cirrhosis, and particularly around procedures that cirrhotic patients might be having. Tell me a little bit about hemostasis and coagulation and cirrhosis, because it's a pretty complicated topic.
Very correct. So when we talk of coagulation, so coagulation involves multiple factors. You've got the coagulation factors, you've got platelets, and sort of a dynamic balance which occurs between these two players. And when the clot formation occurs, when we talk about, say, the clotting factors in patients with cirrhosis, you got the procoagulants and anticoagulants. So liver is the primary source of synthesis of both procoagulants and anticoagulants. So when there is cirrhosis, then there is a reduction in both the procoagulants and anticoagulants. The next player in formation of a clot is the platelets. And we all know the platelets are low in patients with cirrhosis, and to counter this, we've got another factor which we call as the von Willebrand factors. So this von Willebrand factor is actually increased in patients with cirrhosis. So this helps in clot formation. So you got a dynamic balance between both the procoagulants and anticoagulants, and effectively, there is a balance situation, and hence, when we even see clinically, these patients are usually sometimes even more predisposed to developing thrombosis. So that's how the precarious balance is there in patients with cirrhosis.
Absolutely. And I think a lot of our trainees and fellows who are just learning about cirrhosis are surprised by that cirrhotic patients with low platelets and high INRs can actually be prothrombotic.
Very correct.
Clot.
Yes.
So when we think about procedures, I know your article talked a lot about how we think about this around procedures that cirrhotics have. They have a lot. They have paracentesis, thoracentesis, variceal banding. How should we think about how risky those procedures are and when we might need to think about giving product before a procedure?
Right. So the data presently which is available suggests that there can be some procedures which are low risk and some procedures which are high risk based on their risk of bleeding after the procedure. So if we talk about low risk procedures would be like abdominal paracentesis, thoracocentesis, doing cannulation of the central veins. And when we talk about high risk procedures are those which actually involve going through the liver. When we talk about going through the liver would mean is something like a liver biopsies, doing interventional procedures for complications like hepatocellular carcinoma that involves radiofrequency ablation. Then you got procedures like patients undergoing any kind of other liver resections. So these would be the high-risk procedures as compared to the low-risk procedures which I talked about. And when we talk about, say, you said is the giving of blood products. So when we are managing such patients, we are worried about two things, or what we can look at for the assessment of coagulopathy in patients with cirrhosis is two components which are easily available. That's the conventional coagulation test, which involves the prothrombin time or the international normalized ratio, which is the INR. And then we also look at the platelet count. So these are the conventional tests which are available with us. Then we also have activated partial thromboplastin time. So when we look at the data which suggests this, yes, INR actually has been developed for standardization of vitamin K antagonists to assess their effect across the different laboratories to ensure that the results are same and can be replicated. But INR actually doesn't suggest what is the correct coagulopathy in vivo. INR is an in vitro test and looks at only the procoagulant factors. So it's not taking into account the anticoagulant factors. So it may be prolonged, but that doesn't signify that the patient really has an anticoagulated state.
Right. And this is where we get the idea that for patients who are getting a paracentesis who have an INR that's elevated from their cirrhosis, we don't necessarily have to give FFP, right?
Very correct. So when we're looking at low-risk procedures, absolutely there is no indication for correcting any kind of INR in these patients with fresh frozen plasma. In contrast, giving of fresh frozen plasma in these patients who got cirrhosis and associated procedures which they are undergoing may lead to more problems because as we all know, a transfusion of fresh frozen plasma is associated with some kind of transfusion reactions, anaphylaxis, and too much of volume also leads to increase in portal pressure, and the data to suggest that excessive transfusion of blood products leads to even increased bleeding in such patients. So we need to be very careful when we are monitoring these patients prior to procedures. So what we talked about is we should not correct INR. INR is not a good test which suggests you what's the coagulation status. Platelets, we talked about, platelets are low, but we've got other counter-regulatory mechanisms which come into play, and even low platelets are good enough. And even then data suggests that patients, when we look at the thrombin generation test in such patients, the thrombin generation by the plasma in these patients with cirrhosis is effectively normal.
Okay.
So the coagulation cascade is essentially preserved in these patients.
Perfect. So the INR tells us a little, but not a lot, not the whole story.
Very correct.
Very good. Now, what ways might, you talked a little bit about in the article thromboelastograms and some other kind of more sophisticated ways of looking at that broader anticoagulation and thrombotic pattern of cirrhotics. Can you talk a little bit about what those tests look like, how you might use them in New Delhi?
Right. So we've got now is what we call as, these tests are called as viscoelastic tests, VETs. You got various procedures, various tests, like if you got what you rightly said is thromboelastogram, then you got a ROTEM. So the basic difference between the two tests is the mechanism by which the machine looks at the assessment of coagulation, in the sense is that in thromboelastogram you got a cup which oscillates, whereas in ROTEM, it's the pin which oscillates. Essentially, the results of both these tests are similar, but it's the names of the different tests or the components of the test what we get is a little different. But essentially, what we are looking at in a thromboelastogram is the time to start of the coagulation cascade. Then we're looking at, in some time, how much the clot strength becomes, and the speed at which the lysis occurs. So we're essentially looking at these components, and individual components can suggest us whether we're looking at the deficiency of coagulation factors, we're looking at deficiency of platelets, we're looking at deficiency of fibrinogen, and hence assessment with these tests can help us in deciding what kind of specific products are we planning to give in a particular patient.
Oh, very interesting. Very good. Well, thank you so much. It was a pleasure to talk to you today.
Thank you.
Thank you for watching this video. For more information, please visit cldlearning.com.